Hello, thank you for tuning into this webinar. I hope you'll find it valuable and insightful. My name is Sophie Lindwald and I work for BES Healthcare, and I've been organizing the Do No Harm, Know Your Power webinars. Before playing through the webinar, I thought I'd take a moment of your time to briefly explain our campaign, Do No Harm, Know Your Power. The campaign is inspired by changes we've seen in the healthcare system due to time pressures and financial demands, which has led clinicians to make clinical decisions that don't always lead to the best outcome for the client. These challenges have adversely affected patients, leading to an increase in harm. To change this, to do no harm, we want to empower clinicians to say no to equipment that has not been tested to its appropriate standard and give them the power to bring clinical recommendation back into the buying process and make right decisions for the best possible clinical outcome. BES works with various bodies, charities, and industry experts to make information on standards, equipment, and best practice guidelines accessible to you. We also offer free training where needed. These webinars might not change the industry overnight. Still, we feel that they are the beginning of a movement to inspire clinicians, manufacturers, and end users to look for alternative solutions that fit best clinical practice. That was my moment. Thank you for listening and enjoy the webinar. There we are. So hello everyone, and welcome to our third and final, at least for now, webinar from our Do No Harm, Know Your Power campaign, where today we'll be talking about pressure care in relation to postural management. With me today, I have 5 panelists, which include Frances Kent, Anita Rush, Joe McConnell, Kirsty Cutler, and Jacqui Fletcher. And last but not least, I also have my lovely colleague, Diane Hargrove, with whom I will be sharing my hosting duties. And can I just say a massive thank you to all of you for wanting to join us today and share your knowledge and experiences within pressure care. Before we start, I thought it could be great to just have a very, very brief introduction of all of our panelists. So Frances, could you very briefly just tell us a little bit about yourself, what you do, and how it relates to pressure care?
Okay, so I'm clinical nurse specialist for Buckinghamshire, lead for the equipment service and for the specialist complex equipment needs team. We come in where other clinicians are not sure about what they need. They might have problems with pressure care, not sure what mattress. The person might not accept the mattress. That's a big issue for a lot of the district nurses, is persuading people to have pressure care. We find an awful lot of cushions plonked on top of chairs, which of course is a huge problem because it changes the dynamic of the chair that they're already sat in. So 24-hour postural management does make up a lot of the work we do. But when you go in and do this, you then become involved in pressure care and you become involved in manual handling. So a lot of our work involves care agencies, working with the care agencies, asking them to attend when we're doing seating and postural management so that we can show them exactly how to use that piece of equipment and then following it up before we close the case. The problem is that once we leave that house, they are going to do what they want to do and not necessarily what we've asked them to do, and carers leave and they don't always pass on the information correctly. So I've just recently had a patient that we did some teaching with a tilting space chair, and then I rang up to follow up to find out that she had become very confused because she wasn't taking her medication and actually fell out of the chair. Oh. On questioning this, I talked to the district nurse and she's been in and found that the chair wasn't tilted. So, you know, we have all of these problems. We can put the best equipment in, but what we have to do is put the safest in. It might not be the gold standard, but we have to put in what's going to be safe and what's going to be used correctly for that person. And so we work across the board with many, many different clinicians and non-clinical people to try and get the right equipment in and to get it working properly. And that includes care homes as well.
Great, great. How about you, Kirsty? Could you give us a brief introduction about yourself?
Yeah, so I'm Kirsty Cutler. I'm an occupational therapist by profession, currently the clinical manager for the wheelchair and special seating service at Bristol Centre for Enablement. So we cover a large area of service provision in the southwest, taking referrals from the community for wheelchairs and seating. Large proportion of that is obviously for pressure care and pressure ulcer management alongside our colleagues in the community. So it's, you know, an essential part of what we do, but also not just about the supply of equipment, about how we explain what we're doing to the client and their carers and families, and that ongoing education to try and help us all prevent what we see in the community sometimes that results in pressure injuries and pressure ulcers. So I'm really interested in this area, have been since I've qualified. So it's great to join the webinar today. So thank you.
Lovely. And what about you, Jacqui?
My name is Jacqui Fletcher. I am a tissue viability nurse by background, so I've worked in the field of tissue viability for a long time as a clinician, more recently as an educator leading a bachelor's and a master's programme at University of Hertfordshire, but over the last 10 years or so worked in more strategic roles. I currently use part of my time as an independent consultant, but my NHS role is as the clinical lead for the Stop the Pressure programme for England, and that sits not only in NHS E&I but also in the National Wound Care Strategy, where I'm the clinical lead for pressure ulcers.
Great. And Jo?
Hi, so I'm Jo McConnell. I'm an occupational therapist for 29 years. I've always worked in the field of complex posture, mobility and pressure care. And I currently work for Etac as a global education manager for pressure care. I educate globally both clinicians in the field, end users about the correct use of products, and also sales professionals within the Etac company. I've also worked for another global manufacturer. I've worked for the NHS within specialist posture and mobility teams at a regional centre in the West Midlands, and I've worked for a national mobility charity.
Great. And last but not least, Anita, could you tell us a little bit about yourself? Oh, I can see your sound is
Good morning, everybody. There has to be one. I'm a clinical lead for equipment, nurse specialist for Berkshire. I've been in post now for many years. Like my colleagues here, I've been working in the field of pressure care for as long as I've been in post. And part of my role is to, like Francis, is to go out and see patients with complex needs. The sphere of the patients is from children right up to adults. So my role involves pressure care for children as well as adults. I also do a lot of training within my role for the prescribers. I work with social services to educate them on mattresses and beds and pressure care. I do training for them. And like Francis and others, I do postural management. But all of that encompasses the whole of what equipment is. So manual handling, all of that comes into that role.
Lovely. Well, thank you so much, guys. Let's get started with our questions. The first one is a fairly general and a fairly big one that I'm sure we could, spend all of this webinar discussing. But Jacqui, when it comes to sort of like pressure care, what do you see as being the biggest challenges over the last 5 years?
I think one of the biggest challenges we have is the lack of evidence. So the clinicians particularly are faced with a raft of equipment, but there's no high level evidence to say that one piece is any better than another. And some of the big research studies we've had, things like Pressure 2, which took a long time and cost a huge amount of money, didn't come out with anything conclusive. So although it gave us some indication what might be better in very specific situations, it didn't give us very generic guidance. It wasn't a very pragmatic answer. So a lot of the time clinicians are making decisions based on experience, based on marketing information, based on speaking to their colleagues. And a lot of pressure ulcer provision is very personalised. So what works generically doesn't always work for that patient. There's so much more to consider. So quite often you have a lot of conflicting information. I think one of the other areas that we have in a challenge is is we sometimes get the focus wrong. So we've been very focused on counting pressure ulcers. And whilst that's great and it really helps us to know how many pressure ulcers we got and are we getting better, it's become an industry in itself. So now if you speak to a nurse specialist in tissue viability, they will tell you they feel they are pressure ulcer people, not because that's what they want to be, but because the national drive is about getting the numbers right in pressure ulcers. So an average tissue viability nurse will spend about a third of their day just checking if that pressure ulcer is correctly categorized, chasing it through root cause analysis. And it's this huge industry of what's going on. And I think that's something that we are at the minute trying to address and trying to change that. I think another challenge is something we'll perhaps talk about a little bit more, is that there are not good standards. We have some standards, but they don't necessarily address the issues that we need them to. So I think that's three big areas that we have: lack of evidence and conflicting information, this focus on counting rather than on prevention and action, and a lack of standards. And the one other thing just to say I think is a problem is we've been so focused on prevention, and rightly so, we've lost the focus on healing. So once a patient develops a ulcer and we've ticked all the boxes and done the Etac or whatever your incident report is, there's nothing that says, why is this patient now not healed 6 months later? And we're starting to pick that up and say, actually, this needs as much of a push as the prevention does.
So Jo, is this something that you recognise as well in the work that you do?
Yeah, definitely. I really hear that so clearly. That's why I'm nodding a lot. So yeah, I've just been doing a lot of work within my role for Etac, obviously for the new guidelines for medical devices, looking at all the evidence that's out there. And yes, you're correct, the evidence is really patchy. So trying to produce that clinical evidence for the report was quite a task. And we just have to be careful that less experienced clinicians don't jump onto a website of a manufacturer and just read it like it's gospel. They have to be more inquisitive. They have to ask more experienced peers, and they have to seek advice and not just go for what they read, because of course every company out there wants you to believe that their cushion is the best in the world. But like Jacqui's quite rightly saying, are we really looking at the cause of that pressure ulcer? What caused it? How is it categorized? And actually, was it categorized correctly? Because if you go to see an individual in their home, they could be telling you, yes, I've got a grade 4 pressure ulcer. Well, who's actually categorized this? Who's been the professional involved? And then they wonder why the cushion they've been given isn't working correctly when they haven't been followed up on. So things can very quickly go wrong. And it's getting to the root cause of what's happened here, what's the history, what's been tried in the past, and why they've just been handed another cushion to think that will solve it when we haven't really got to the root cause of what the problem was. Sorry, Jacqui.
Not at all. One of the things that I forgot to say, and I think it's important, and it's great to see the team on this, is silo working. So pressure ulcers are a tissue viability problem, but actually this whole group of other therapists out there that actually spoke to them a little bit more, and I'm increasingly working with the moving and handling teams and equipment providers, and if we got those people in a room together more often, I think we'd solve problems much more quickly.
Yes, yeah.
How about you, Jacqui? How do you do you have similar experiences of, therapists kind of just choosing a cushion, for instance, based on the manufacturer's websites?
I don't think therapists do. I think we have some less experienced, it would be wrong to say therapists. I think less experienced clinicians all make the same mistakes, and you make the decision based on the best information you have at the time, and companies are very good at selling their equipment. That's their job in life. So I'm not knocking what the companies do, but they don't always give you a balanced picture. But anyway, to balance that, I would say we sometimes over deny company research as well. Some people are very good at saying, oh, that research was sponsored by a company, it can't be good. You need to did the research, you need to look at the quality of the research, and you should judge evidence on its quality, not the person who is showing it to you.
How about you, Anita? Do you have any similar experiences?
Yeah, exactly the same. But I also want to say is something that I come across all the time is that people are task orientated. So again, you're finding that people will go out and do the task, and it's probably not, we haven't got that holistic approach anymore to the management of our patients or individuals. And I work a lot more with OTs. OTs are becoming very, very pressure management aware. And I don't know about Jacqui and Joe or the rest of you, but I'm finding that more and more OTs are wanting to come into the training because they want to have much more awareness.
Great. And how about you, Francis? Do you have any sort of experiences as well in this? Do you like to share?
Just very similar, really. I think the fear, the worry is that clinicians have a little bit of training and then they think they know it, and that I find quite frightening. And so the companies, I think, have really stepped up through COVID with their training, and that's been brilliant. But the problem is, if they go independently to, and I do a lot of training like Anita does as well on the mattresses and the cushions, etc., and other equipment that we hold within the equipment service, and the companies go in, directly, maybe because we're a joint community and acute trust in Buckinghamshire. So the acute sector, mainly the OTs, will come to me if there's an issue as well, or for discharge problems. But if those companies go and do, a lot of training on different chairs, then there's all sorts of different equipment that's being ordered and then coming back into the stores. And there's no kind of, I hate to use the word control, but I think it is just, it's monitoring what's happening and ensuring that people are doing the same thing, and that people who are ordering equipment are aware. And we keep telling them, if you prescribe equipment, it is your responsibility to know that you understand it, to go and see the patient when you've ordered it, and to go and check that it is working correctly, and train anybody who needs to be trained on it. And so I think that, and there's a big disparity over the whole of the UK. Every county works differently, and every county has different equipment, and not everybody has. It's unusual that, for a nurse to be doing the work that both Anita and I do. Now, I've been doing this job for 26 years this year, so I started in this role, and it was a very new role at that time, to have nurses in the role rather than OTs. And I also work a lot with OTs. And I think, like probably with Anita, a lot of people think I am an OT as well, because we go and we look laterally when we go out. And the task orientated that Anita talked about is very true, because they're told you've got so much time, that's what you go and do. But if we don't look laterally when we go out to do an assessment, we miss some of the key points that are causing the problem. And Jacqui, I'm sure, finds this, so everybody finds it, that we're asked for advice on things. And when you actually really delve down into what the problem is, it's not what they think it is. They will say it's the bed, it's the cushion. And then you ask them, how are they sitting? Are they getting out? How are they lying? And if you do go out, you actually find that the problem isn't what they perceived it to be. It's something completely different. So we have to look laterally.
Jacqui, you have something you wanted to say?
You're on mute, Jacqui.
So it's picking up on the different resources that are involved, because it's great to have the teams involved, but one of the things we sometimes see is a conflict between health and social care, and that is the reason thing. It depends who pays for which piece of equipment. So you might have social care purchasing the bed frame and health purchasing the mattress, and you might find the different sizes because the two didn't speak to each other, or they're ordering things that just don't work together. And that's such a huge national problem about how money's allocated in different ways in different organisations. I think it just adds layers of complication to things.
I was going to say the other problem we have is the cross boundary. So if the person has, so for example, in Buckinghamshire, if the patient has a Bucks GP, but they live in the next county, health will go and see them. But if they actually have an issue where social services would step in and they live in the next county, our social services won't, because they don't pay their council tax then. So you have this big hole where in one county health provides one thing and social services provides another, but we go to the next county and it's the opposite way round. And there you have this person who falls into this big black hole and it goes round and round and round, and nobody's saying it's not us because we don't do that. We have it all the time on our boundaries. And eventually what we do is that we go, just, do you know what, we're going to go and sort it. Because it will go round and round, and that poor person hasn't got a clue, or not, and the relatives don't, about how they can get help for that person.
So Kirsty, and the issues that have been discussed around sort of like silo thinking, the lack of training, the counting of pressure ulcers rather than prevention, is that something that you see as well in your work life?
Yeah, absolutely. I mean, I've been doing some work recently with our inpatient tissue viability team, and one of the drivers, as you say, is very much around the numbers, reducing the numbers of the incidents of acquired pressure ulcers in our organisation. That's a big driver, and having to get those down, having to report and record those. And I think, you know, that needs to kind of change, as you're saying, into more of a management and more of a treatment and follow-up regime. And a lot of these things point to standards, don't they? Point to having some standards, but also standards across all agencies. So more joined up working, more education that's joined up, because I think, like I say, we all are sometimes a little bit more disjointed, not joined together working, and sort of silo working in a task way. So all of those things, you know, we do actually experience. And what is very interesting is it's different in different areas. So in the West Midlands, I know we did a lot of work with our tissue viability team on joint education, and that started to work really, really well. But then, you know, I've moved roles, come down into the Bristol area. I don't even know who the tissue viability team are in the community, you know, and they don't refer to us. We don't have much involvement with them. Their coverage is not the same as the team in Birmingham. So, you know, differences and variations across the country, and a lot, as you say, Francis is saying, you know, about the procurement issues, the difficulties of procurement, that, you know, services just and clinicians will choose a product because somebody's put it in front of them, and that's very prevalent. Yeah.
Great. So all of the challenges that you guys have talked about, how have they sort of been exacerbated during the pandemic? Francis, would you like to start with that one? Can you hear me, Francis?
Sorry. So can you say that again? Something waylaid me there.
That's all right. So all of the challenges that we've sort of discussed within pressure care, how have they been exacerbated during the pandemic?
Okay, I think in general for the equipment service, there have been issues with them being to get the equipment, because there's been, the companies have had huge problems with getting the materials to make that equipment. So there was a big problem at one time with the companies who make all the different foams to get the components to make the foams. So that was a problem. So, and I know it's across the board because, you know, different areas are managed by different companies. You know, there's NRS, Mediquip, Millbrook and in-house, but every single one of them has struggled, and they've had to try and find close technical equivalents of what it is that you hold within your service. Certainly in Buckinghamshire, every time there's been a replacement item sourced by our equipment provider, they have told us clinically and asked us if we will accept it. On the whole, we've said yes. Sometimes we've said no, it's not even it's not a close technical equivalent, but they've been so stuck because, of course, every county has been chasing the same equipment. So even if those companies have had a store, you know, they've had a build-up store that they've set aside, they've been running out, and everybody is, so they've had everybody going to all the companies trying to find replacements. Bed frames was a big problem at one point as well, and obviously without having a community bed frame, you can't put some of the mattresses on divans and double beds. So that was an issue. I think it's, if I think about what I saw when I went into our stores on Monday, we could hardly get in there because of the delivery. So I think they're catching up with some of the backlog. Throughout COVID, we've done more and more online training, which MST's been an absolute brilliant medium to use to to catch people, because of course they've all been so busy, and because it's, I mean, all counties are big, but ours is a very strange shape, and so to it, even when we had before COVID, getting staff to come from the community to attend training centrally was actually asking quite a lot of them out of their day when they were out and about seeing patients. So I would always try and go and see them, and sometimes that was difficult. So being able to have online training where maybe you only caught 2 of them, you know, you would say, I'm setting aside 2 hours and I'll just keep running this over, and if 2 of you can attend, that's absolutely fine, because at least if you could catch 2 of them. I think a general problem anyway outside of COVID is that you do training. We've recently, 2 years ago, we introduced a new mattress system and we did masses of training. There were issues, so we did loads more training at the end of last year. The emails that I send out say, you know, you've got to attend this if you're going to issue this equipment, because it's important you understand how the pumps work, or whatever it is, how it works.
Yeah.
But you still find that they don't attend it, and then you go out and you find that there are still issues and they're asking the same questions, or they attended the training so long ago that they forget it because they've got so many other things that they're having to take on board outside of equipment. So I don't think there's ever an end to training for anybody. But the biggest problem is that the carers, and I do feel sorry for them, I think they have an appalling job. They don't get adequate training. They're paid peanuts for an appalling job. They are expected to go in and face the most unbelievable conditions. And we're talking across the board now. I mean, yeah, I do children up to adults, but when we're talking about our plus size people, and some of those carers go into unbelievable circumstances and are expected to manage that person, manage their skin, and don't have any training. They're not paid to attend training. They don't attend our equipment training because they're not paid to do so, and yet we expect them to understand it. So that disparity between social care and health, and of course sometimes, again, I'm sure we all find it, you go in and do training, whether it's manual handling or anything, and sometimes you kind of get that them and us, and who does she think she is coming in to tell us what to do, because I've been doing this job for ages and I know. That's another problem. And if we don't break this down, we expect them to wash patients properly. Yeah, many times I've gone in not long after the carers with a district nurse, and we have cleaned that patient, that person in the bed. I think that if we don't address that problem with carers, they are our ears and eyes, aren't they, when they're at home? And if they don't get it right, then we're going to continually have problems, and it adds to our workload all the time, because they're not, we can't follow up, and they change so rapidly. And the stories you get from some of the families about the carers is just, it's inexcusable. But some of the carers are wonderful. They are wonderful, but that is a massive problem.
Yeah, I can imagine. How about you, Anita? What's been sort of the issues you've experienced during the pandemic and post-pandemic?
I think really the same as what Francis has explained fully. It's all about people. We, like Francis, we introduced a new mattress. Getting people to the training has been problematic. However, we did put in place a triage system where they weren't allowed to order the mattress, and unless they've done the training, which has been a bone of contention, may I say, for most of the people, because they just thought that they could order it, and I'd just let it go, and we didn't. We were very quite strict on that, because unsafe equipment has the potential to cause harm, and this is what I try to get over to people. And also it's their registration, because they are prescribing for it. So much of the frustrations, I think, is what we've all felt really through the pandemic. Lack of equipment, getting equipment delivered. A lot of, for me, was unsafe discharges, and also getting equipment into hotels for patients to be discharged into hotels. That was a big one. We had 2-3 hotels that we had to kit out with equipment for people to come from the acute sector back into the community, and the care homes, because the looking after the care homes. So more or less the same, really. I'm not going to go much more into it because I think everybody's had the same experiences.
Mm-hmm. How about you, Joe? I saw you nodding when Francis and Anita were talking about lack of equipment.
Yeah, it's just really frustrating that the pandemic obviously put everything else on hold, and that people were allowed to really accelerate through the categories of injuries because they weren't a priority, because everything was about COVID. So I had people contacting me via email saying, we urgently need you to go and assess this. I also have an assessment role within my post, so I do complex assessments in the UK to support the products. And yeah, it was just like people had been sort of put on hold because everything had to stop for COVID. So somebody who may have been at category 2 had very quickly, as we know, progressed to category 4, which is just so sad that, yeah, this is what's happened to us because of COVID. But hopefully it's taught people how quickly things can change. We've been talking about it for years, all the Stop the Pressure campaign. Everybody should know how quickly things can change, but really until you see it before your own eyes, it's alarming. And what I'm always appalled by is that the amount of clinicians out there who are really not confident in the basic anatomy of the pelvis and understand why somebody's having this recurring pressure ulcer. They don't understand the difference between pelvic obliquity loading. Why are they loading on one IT, or why are they actually loading on the sacrum? I think, the amount of clinicians out there that just aren't confident with the anatomy of the pelvis and how this impacts on support surfaces and pressure ulcer prevention.
Francis, I saw your hands up.
Yeah, I think one of the other things as well that is a big contender in the provision of equipment is the fact that within their own home, you have to do a lot of negotiation for people to accept it. I was out the other day and I said, so, being diplomatic, at some time you're probably going to need to have a community bed. Have you thought about this? I mean, and there's just nowhere to put it. A huge problem, and some people don't want to accept it. They don't want the person to be downstairs. They don't want to remove things within their lounge, in their dining room. They don't want to. I think a lot of them with neurological conditions where they're actually beginning to get worse, is that they don't want to accept that they need additional equipment. And that one, it's a sad one, because you kind of try and tell them that let's get it ready now before that crisis happens and before it becomes a really big issue for you. Let's just get it ready for you. And especially with the MNDs, which is just absolutely appalling condition. That is a big struggle because, of course, they change so rapidly sometimes, and you want to get equipment in before they have the crisis on a Friday afternoon, which is, or before a bank holiday. You want to be able to get the equipment in there and get the equipment service to be able to deliver it. And again, every single equipment service has got a different specification on how it is managed. We are lucky in Bucks because we've got 5-day, 3-day, 2-day, same day, next day, and 4-hour deliveries. And 4-hour deliveries were, first of all, for palliative care, where there was a window to get them home before they wouldn't be able to get them out of the hospital. Now, with D2As, they're using 4 hours all the time because it's just, right, you've got to get them out, they've got to go home, they've got to go to the care home. More equipment is going into care homes than we've ever put in before, where normally we wouldn't have put it in, we'd expect them to have it. So that issue of getting equipment out to people timely has also been an issue, because how many drivers, how many more drivers have they needed to actually get the equipment out on 4 hours? But it's also, as I say, getting people to accept the fact that they need that equipment.
Great. And Jacqui?
I think there's kind of some really big problems that we have seen during COVID, and they changed over the COVID period. During the first stage, everything was chaos. We all know it was chaos. It was all about PPE. We had so many staff off sick, as well as patients being incredibly sick. But as we progressed through, we saw some real changes. And for me, one of the big things, I think, Anita, you mentioned people's knowledge and skills and different people, was about redeployment. So I know I worked in an acute organisation during the first waves of COVID, but it was the same in community. So people whose jobs were no longer active, school nurses, outpatients nurses, theatre nurses, because everything was reduced, were being redeployed to cover gaps. So we had school nurses working with our community nursing teams who were going out to see patients with pressure ulcers and leg ulcers, and it was horrifying for them. It was beyond their skill level. They hadn't seen these for years, and they were doing the best they could. And what happened was, TVNs also got redeployed. So the TVNs saw all the wound care patients, and we put the school nurses where they were most confident and competent. But that happened across the country. People were being moved into different roles because people were sick, or they'd been pinged more recently, and we were suffering staff shortages. From the patient perspective, patients who were shielding didn't want to see people. They wanted to be safe. So there was this reduced footfall from both. We hadn't got the staff and they didn't want to see us. So that category 2 going to a category 4 happened more than we would have liked, although we have no data to evidence that. We are, very confident really that is what the problem was. We saw a change in our patient profile. We rarely proned patient, but if you look at what was happening acute, we were proning patients all the time. We didn't have the right equipment. We were rapidly having to make decisions about which beds we needed to do for that, which mattresses we need. Were the head supports? How did head supports work? Did it give us pressure ulcers in different places? How did we fasten our tubing and all those kind of things? We were sending patients home, consciously proning them. That meant we needed lots of pillows. People didn't have pillows. And then as we've moved through COVID, we've seen the changes in our workforce, where I know certainly people of my age, many of them have had enough and taken retirement. They're very demoralized. They are exhausted mentally and physically. People now, if you talk to them, are already moving into being redeployed. They're looking ahead to winter with the double whammy of flu and, maybe a resurgence, maybe a next wave. And people are genuinely more than anxious. They are petrified of what it's going to be like. So I think all those problems that we've talked about, some of them, are irrelevant. They really don't care. They just want to make it through from today to tomorrow and keep themselves and their colleagues and their friends upright. So I think there are some really, really big challenges, and there's been some huge positives. All that digitalization has been amazing. We've saved so much time, but a digital consultation is not the same as being next to a patient, putting your hands on their skin. Or I think, Francis, you mentioned their environment. When you see them in front of a computer, I wouldn't want to tell you what behind my computer looks like, and it's like that in a lot of people's homes. You pick up so many cues from physically seeing them in their bed, whether that's in hospital or in their own home or in their care home. It tells you so much about what happens, and that is about, are they using the equipment? Are they using the equipment properly? Can they not afford to plug it in? How much space have they got? And you don't get that in this situation. So it's given us some real positives in terms of digitization, but we need to temper that with a little bit of common sense about, we do sometimes need to be face to face.
So yeah, Kirsty, when we've talked previously, you've mentioned that some of the challenges are sort of like lack of staff, and that you have this huge backlog of users that need their equipment. Could you tell us a little bit about that?
Yeah, I think we're suffering a little bit now, obviously being on stop, as we call it, or through lockdown. Our services had to pull back really and only see those most urgent cases. So those most urgent cases were most definitely pressure care, and our therapists were still working within that time when we had notification or referrals that indicated that we would need to continue to assess that person. However, as has been said, if that person wanted to keep themselves safe, or they were shielding, or they didn't want other people in their home, that was then a very difficult situation to manage. What we've ended up with now is we've not got the recovery from our waiting list that we would have liked to have seen, mainly because of staffing issues that we've got now. Obviously, this is not unique, but we have staff off with long COVID. We have staff off with stress. We have staff that have since all of this has happened, have retired. They've felt it's their time to retire, and that's what they've done. And we're struggling to fill vacancies, which means, you know, we're not seeing the same level of patients that we saw pre-pandemic. So one of the difficulties that we're struggling with now is we categorise anybody with a new pressure injury or an existing pressure injury, but that something has changed it, or they've had a new piece of equipment. We would class that person as at risk within our service, and they would get an appointment within a 2-week period. That's how we manage our service. However, we're having to stretch that now. We're having to cancel other patients' appointments to get those appointments planned in, because we've got such long waiting lists and pressures of other services. And what often happens is that I'm and other senior staff are making decisions about which patient is most important. That is really, really hard and a very, very unpleasant position to be in. All of our patients have got needs, and all of them are really important, but having to choose a patient who needs to be seen before another, that's a real pressure. Yeah, and one which is very difficult to manage. We're not sure how we're going to get back on top. We are just managing day to day and having to look at those risks as they're presented to us with the service that we have. And obviously compounding that then is the supply issues. So, you know, we obviously we don't hold lots of stock here in our service. We're not, although we're a big service to manage, we don't have a big storage area. So we're having to rely on deliveries, and they're not forthcoming, especially for the more complex products. So we are struggling with some of those supply issues for pressure care products that we use. So yeah, we're in a little bit of a tricky situation at the moment within our service.
Yeah, I can imagine. And Frances, I'm not sure, did you want to add anything to Kirsty or to Jacqui's points?
Yeah, well, to both actually. I mean, although there's two of us, so I've got a senior OT who works with me. We do prioritise, but we cannot do. We're having to slot in urgents over and above the referrals that we've got, that we've already deemed to be fairly important. But we do tend to see people within about 4 to 5 weeks. But our community neuro teams are in serious trouble. We've had a conversation with them because theirs is like 2 or 3 months, and they have been told they cannot have any more staff. And I think they are very distressed about the decisions they're having to make about who they see and when they see them. We continue to see patients, like Jacqui said, you have to be face to face with people. You can't, it's certainly in the role that we have, you have to be with them in their own home and have hands-on to actually do that assessment. A lot of teams didn't, and they're now seeing patients again. I think our wheelchair service has got a fairly long referral time, but they are picking them up. Our social services team, NRS, who runs our stores, have got OTs, and they've actually been picking up some of the OT waiting list for social services to get them in, because of course, again, people haven't been coming forward during COVID. So yeah, there are issues with the length of the waiting list now, but the fact is that you're having to go out and see these urgents that somebody will ring up about, and you think, I can't not go and see them. So it's just putting other people back all the time. And the kind of work that we all do isn't a quick fix on the whole. It's the first visit to assess, and then there's all the background work before you then sort out the equipment, the chair, etc. But the other thing I was going to say, when we did our guidance on seating, and I know it's similar, we did a survey monkey through the NAP membership to see how many counties provided chairs and sleep systems, and it was interesting to see how many counties said we don't do chairs. And there are still counties that don't do chairs, or if they do, they just have a small budget, or it has to go before a panel. That panel might not sit for every 6 to 8 weeks, and then they have to make a decision, should that person have that vital piece of equipment for horrendous postural issues. And they might get it and they might not. But the evidence there is with, if you have identified that a person requires a piece of equipment to address a problem, it should be provided. We don't have that in Bucks. We have equipment coming through that is screened, but there's certainly not a waiting list for it if it's essential. Chairs, sleep systems, or anything else, if they need it, they get it, so it's not held up. But certainly in some counties, there is still, we don't provide, or it goes before a panel.
Okay, and then moving on to our next question. So we've mentioned it a little bit before with the sort of like silo thinking, but Kirsty, who gets involved in your area when it comes to pressure care in terms of like other clinicians, families, carers, etc.? What's their sort of involvement?
Well, I think in our service, obviously, if it was an assessment for pressure care, it would be the primary aim of our therapists to complete that assessment. However, the staff within the service all need to have a real awareness of pressure care issues and where and when to highlight that. So that includes our support staff and our administrative staff who speak to patients and carers on the telephone, so that they can prioritise and move that referral into the right area to be addressed by the clinical team. And when we do speak to the obviously the client themselves, we do that assessment, then this is where we need to think about that joined up working. So everybody that's involved with that patient at the time, but who else needs to be involved? So we would then involve who the district nursing team are. If there isn't an active team, we would refer that person in. We would make referrals to the GP as necessary. We might even, if they've had an inpatient stay or they're an inpatient currently, involve our own tissue viability team. So this is where I think there's the education of when you see something, you're not just dealing with what you see, you're dealing with the holistic elements of the patient and the whole elements of what you see and who you need to then refer on to. We all know on the panel that we've been in, we've had experiences and we've been in situations where terrible injuries may have happened, they may have worsened, and had we known about that earlier from our community teams, or had they asked the right questions, had they seen that there's a wheelchair in the corner when somebody had been on bed rest for 4 weeks already and made that referral, that patient may not have experienced the pressure injuries that they had. And this is where the education comes in, the use of standards, and just that holistic view of the patient, joined up records, all of those things are really important, and I don't think happening well enough in any of our areas really. So that's who should and who does get involved, but a lot of that is about education and making sure that we're not just task orientated, as somebody mentioned earlier. That's a really good phrase really, that we become very task orientated because of the pressures that we're under, but actually for pressure injuries you need to think more widely.
How about you, Anita? Do you recognise something similar in your daily practice? I saw you nodding a little bit.
Yes, I absolutely do. Yes. Well, who gets involved? Well, I think it should be everybody. Personally, I think that everybody should be involved. I know that, as I've already said earlier, that our OTs are very keen to get involved. What I do find though is that if there's anything around postural management or seating, the district nurses are very quick to send that back to the OTs to do. And what we're trying to do is encourage the district nurses to actually have more training and more awareness about seating, because they see all the pressure sores, so do the OTs, and they always say if it's at the bed, they never think about the seating. And so we need to really, there should be such a good education pathway for the nurses. And during COVID, I did work with a company where we did put on some modules, virtual modules, and it was really very encouraging to see so many district nurses attend that training. And it's the same with wheelchairs. Oh no, it's not our job. They just plunk a cushion on it but they don't think about the person's posture in that wheelchair. It's just get a cushion from the loan store and then just put it on, and it doesn't always work. So yes, I just think it's everybody's responsibility.
Terrific, Nadine. What about you, Joe? Do you see something similar in your work with Etac or in your independent sort of like work?
Yeah, I do really. And basically there's just not enough education that can be done. And I'm fortunate that I'm in an education role, so I'm able to reach out to a lot of people, both really experienced people who, like's been said already, have ended up in a role where they're not that confident. So they need some extra additional resources and support, but also in areas where people just are too afraid to ask. There should never be a stupid question when we're talking about somebody's skin integrity. And I like to scare people a little bit by just really saying, you're putting your name to this. You're the clinician that's signing this off. You can't just always do what you've always done. And just because it's on your equipment list, it doesn't make it right that you're just signing it off. If you think that's the wrong piece of equipment, you go back to your manager and you query it. You say, these are the facts. This person has had this history of higher category pressure injuries for X amount of years. We're not getting to the root of the problem. So, some services are excellent at this. Other services are so driven by numbers, by, the pressure of getting these people seen, especially now post-COVID. But as a clinician, I always say to them, it's your professional registration and your name that you're putting to that report, that you're date stamping and saying, I've given what I feel is suitable. And if you don't feel it's suitable, please do not put your name to it, because you're better off being told off by your manager for going outside of range than being told off by HCPC for actually not keeping up to date with current practice. Having just renewed my online today, I'm very aware of this, that we're all so scared of, it's not on a list, we've gone outside of provision. Actually, remember why you trained as a clinician, remember why you're doing that role, you have that responsibility within your hands, and actually you need to do the best by that person. So just because something's on the equipment range doesn't mean that it's always the right thing for that person due to so many pressures out there.
Okay, let's crack on with our last question, and then we'll have a part 2 where we can go proper in depth with our final questions. So the final one is basically just, what could and should the future of pressure care look like according to you guys? Let's start with Jacqui.
It's a really big question, isn't it? I think
very unfair.
Massive.
No pressure.
If you can answer that, Jacqui, we've got the problem solved.
I've tried to look at what I felt the challenges were and will the future address that. So I think for me, some of the future will be, we will have more standardization. So certainly in England, and I can only speak for what's happening in England, we are working very hard to put a pathway together to say, based on the evidence we've got, which is, as we know, wholly patchy, but based on the best experiential evidence we've got, we should, as a minimum, be doing. And in the same way that we've got a clinical navigation tool for lower limb care, have a clinical navigation tool for pressure area care, that will allow us to do some work piloting that, capturing data around it, and looking, so we can say this is the minimum standard you should be doing. And that might not hit 100% of the patients, but it might, for 80% of the patients, take some of the hard work of the thinking away. And I'm saying that in a positive way. If things are standardized, it really helps you to spend more time on the patients who need the time. And digitization is going to help us to do that, because at the minute we have this wealth of data without the quality or the proper use of that data. So if we have a piece of work with a pathway that we implement in a consistent way and we capture data from that, actually that gives us evidence. It might not be an RCT, but it shows us that if you do this consistently, what's the outcome? And I think those are really key things. I think that the other big element is the team working thing. So you've all been talking about team working and who should be involved. But for me, one of the big changes we've seen in the last 10 years is the science has changed. So we were all focused on pressure. We've moved to talking about shear and deformation. And actually that's really changed our thinking. Educationally, that's a big challenge to get that message across, because people understand pressure. You can press a blood vessel, cut it off. Shear's harder. It's harder to explain how to ameliorate it. How do you stop patients getting shear forces? Just manual handling causes them to shear. Just sitting causes shear. And this postural stability has become far more important. So I hope in the future we have better understanding, better models and ways of explaining it, and it becomes a more common component of what we teach. So, so in 10 years' time, clinicians understand shear and amelioration of shear and deformation, as well as they understand prevention of pressure. And that will really bring this multidisciplinary group together. We haven't mentioned podiatrists much today, but actually we get lots of pressure ulcers on heels, and podiatrists know a lot more about feet than most of us do, and it's bringing those together. The biomechanical engineers have done such good work for us, but sometimes they talk like up here, some of the words, and it's translating that into a language that's understood by clinicians. And some of that's time, when they're first exploring these topics, it's all quite theoretical, and finite element modeling doesn't mean much to your average clinician. And I think another point, though, is recognition of that clinicians are clinicians, and they trained as a nurse, a physio, and OT. And suddenly we're throwing biomechanical engineering at them, we're throwing biochemical information at them, and it needs to be in an understandable way. So I do think in the future, we've got huge potential to work together better, to use digitisation, to build our evidence from standardisation and from pathways. In terms of negatives, I think there's going to be problems we've seen from COVID. So I know one of the things that we've been talking about in the TVN network is an increased number of patients we're seeing with contracture. And that has been because of reduced footfall, patients not being seen as often, it's happening. I know Pupis, which is the Welsh wheelchair service, is saying about 30% of their patients have got contracture at the minute, which is high. I think we will see changes in procurement in the same way we have seen changes in dressings. That's going to come to equipment, and that will make a difference. I don't know if that's a negative or a positive. It's just different, and it'll be a way of change. And I think the negatives will be around staffing. It is going to take a while to stabilise our staffing and get the level of experience that we've lost recently. And some of these new roles and new titles are really amazing for health, but they just need to bed in, and we need to be sure what's doing.
Great. And Frances, you're the one who needs to leave fairly soon. So could you give us an answer as well to this sort of what lies ahead for the future of pressure care?
I think, leading on from what Jacqui said, I think I've always thought over the years, with all of the sessions that different companies put on, that BHTA have put on some amazing ones because they've been involved in international research on deep tissue deformation and all of the work that's been done there, and through the EPUAP. It's always the converted who go to these, and how do you get that message down to the people who are on the ground floor? Because we understand it, but we get to go because it's part of our role to go and learn about it. And of course, those tissue viability study days that used to be loads of have long gone. And I think getting that message and that understanding to people is the difficult one. I think, all of the material is out there to use. The evidence, as Jacqui said, and the work that's being done, it's all out there to pull together. But how do you get it down to those people who really need to know? Because otherwise they go along with what has become standard for donkey's years in understanding of and how often you turn, and all of the rest of it that we've been doing forever. It's getting that deeper message down. And it's also down to that immersion, that the words that we use, immersion, to reduce pressure, to actually redistribute pressure. It's how they understand why that helps, because we've still got people who think alternating pressure, that's it, it's got to be, that's it. They don't kind of get it, but if you immerse and redistribute using the right mediums and the right equipment for that person, for that individual person. And sometimes I've been through 5 different mattresses and things before I found what works for that person, because sometimes it is about the pressure, but for some of those neurological conditions, it's comfort. And if they're not comfortable, they're not going to use it properly. It makes a huge difference. So, understanding the equipment and the person and what you need to do, and getting those people to understand how equipment can work to reduce that is important. And I think the other thing about, you said about contractors, Jacqui, I just feel that people go into a care home and it's like care home staff just think, you know, once you get into a care home and you're elderly, demented or whatever else, you're going to get contractors, if that's the word they use for them, because it's all, that's what happens. So the lack of understanding about positioning in care homes is another massive problem, because we get called in and you've got some people who are becoming almost unseatable because of their contractures as well. And to try and position them in bed and to walk away using simple positioning equipment and going back in and finding they're not using it properly. Again, it's back to education and getting to people on the ground level and getting to understand what it is that is important and why. I've found that frustrating for years. End of.
Yeah, I can understand that. If Jacqui and Francis, if you guys need to leave while I talk to the rest of the ladies, then pleasure to have you, and I'll get in touch with you regards to our part.
Okay.
So
lovely to see you all.
Yeah.
Okay, bye for now. Bye.
So how about you, Kirsty? And what do you see the future of pressure care to look like?
I think having people as experienced, you know, as we've got on the group today, round the table to actually say, how can we do this better? Excuse me. So, you know, we've come up with some themes today, really, and there's this issue of joined up working, this issue of education and standards. And I think, you know, some things that we can discuss next time are around some of that thinking. But I think, you know, nursing standards and care are kind of there. They get trained on this stuff. It's part of their core nursing skills. It isn't part of the core nursing therapy skills as such. It's on the periphery of what we might learn as an undergraduate, and we need to be better at education and training alongside the standards that we need to use. Joined up documentation, all of those sorts of things. How can we use the current standards and the current work to inform another a bit of work that extends to the professionals working in and around the community, and, you know, so that it becomes more of a seamless process. You have an inpatient stay, you have a community setting, you have the therapists in the community, you have the tissue viability, you have the wheelchair and posture 24-hour management services, and it becomes a joined up way of working. So, you know, I think working towards that with starting off the discussions such as this and moving them forwards and getting some motivation and some drive behind it.
Great. And Anita, what's your point of view when it comes to the future of pressure care?
I suppose I'm going to I'm going to be controversial.
Wow, we like that.
All right.
Go for it.
Because I think what we miss out is the basics. I'm sorry, I think, you know, things have got very technical. We're trying to expect our prescribers to be engineers, to be all these complex equipment out there. And maybe, and I did this a few weeks ago. I know it's not part of this, but I did this a few weeks ago where I had a plus size individual who was 64 stone. And I had to go right back to basics, back to sliding sheets. Nothing that was technical, nothing that was complex would just work for this individual. And we went right back to basics. And I think I agree with what everybody else has said, that basics needs to start at the training. And it needs to encompass everybody, not just nurses. We should not be putting this in pressure care is nursing, seating is OT. What about our physios? What about our podiatrists? It should be encompassed with all professionals within the health and care homes. So I'm just being a bit controversial there, because I think if we can get the basics right, we can put the building blocks in.
No, and I think that's a really good point. How about you, Joe? Where do you see the future of pressure care?
I just think I hope it receives the respect it deserves, and I hope it's viewed equally as other health complications, other health conditions, or that people remember that skin's the largest organ in the body. I feel that's forgotten so often. And I know we have to have equipment lists. I know the pressures of health and social care, but I don't feel you can just put these high-risk individuals with a history of these, you know, life-ruining, long-standing pressure injuries into a category that says this is what's on our list, this is what you'll get. That is so wrong, and nobody should be putting their name against that. There'll always be the 80-20 rule, and 80% of people probably can be dealt with quite sufficiently from those lists, but the 20%, and the ones that I get asked to go and see that have been on bed rest for 2 years, that are just lying there waiting for surgical intervention, actually when they're given the correct equipment, when they're offered the opportunity to try different things, that they can actually be healed. And I've seen it so many times. So encouraging people to look outside of their box, to challenge the equipment lists, to not feel scared of doing that, to feel confident that they're a healthcare professional that feels confident to question things, is what I would like to see going forward. And yeah, as much joined up working as possible, and as much education, right from what Kirsty says, right from the student level, to make sure we're training to the highest standard in the UK.
Thank you so much. Thank you. And Diane, you get the final word.
I guess it is just to say how much I think everybody's resonated the thoughts and kind of fears and frustrations, and also hopes of the challenges ahead. And I guess one hopeful thought is that there's never been an area such as this that's more crying out for integrated working and education and dissemination of that throughout everybody, all the stakeholders across the piece. But also perhaps in a post-COVID environment, we've got an opportunity with our better understanding of digital technologies and our more openness to this sort of blended approach to maybe have some innovative approaches to that kind of integrated care. And this maybe is somewhere to start it, you know, and I feel enthused that we can do this. So yeah, so thank you everyone for that. That's my thought. Yeah, so that will be it for today. So thank you so much, everyone, for joining us. And as mentioned before, we'll have a part 2 now, where we'll go into more detail about, you know, best practices, approaches for 24-hour postural management, as well as looking into equipment provision. Yeah, thank you again for joining. We'll have the resource list as well after our webinar, so it's easy for everyone to learn more about postural management within pressure care. Yeah. And yeah, thank you so much again.
Thanks to BES for hosting it. It's been great. It's been great to be involved.
Oh, lovely. That's so good to hear. That's what we want to hear. That's why we're doing it.
Yeah, that's great. Thank you.
Thank you again for watching our webinar about pressure care in postural management. We hope it gave you some new perspectives and insights into the challenges in pressure care and how to solve them through more joined up thinking and a standardized approach. To sum up the key points from the webinar, when it comes to pressure care in postural management, it's important to have joined up thinking so that you're seeing the different parts involved in the patient's care, such as joint quotations and similar training for OTs, district nurses, etc. A key challenge is that there's a lack of evidence when it comes to choosing a lot of equipment. There's also a lack of generic guidance and standards when selecting equipment. There's a big focus on pressure ulcers and counting pressure ulcers, which can result in a lack of focus on preventing ulcers in the first place. Clinicians don't always have to go with what manufacturers recommend, but can be more inquisitive and ask questions about the equipment to ensure that it provides the best quality of care to the user. We hope that this is a step in the right direction toward understanding and integrating a more holistic approach to pressure care in postural management. We hope to inspire clinicians and the key decision makers to be empowered and make the necessary changes to improve our healthcare system. We are more than ready to include and gather more people and organizations in our movement towards a healthcare system where there'll be no harm and the best outcomes for patients are achieved. Thank you for your time.